Hey Shiva.
Hi Zahid, nice to hear you. And I mean, since you were there in the last patient, I will tell you what happened. I downsized to a 10/8 MFO that was readily slipping out on 2 occasions. I tried a 10/8 regular duct occluder device that also came out. So we have removed the sheets. I did finally an aortic root angiogram and showed that there is no AR. The transesophageal without any catheter across also did not show AR, and we stopped the procedure there. Now coming to coming to this patient, in this ASD session, we thought of demonstrating 2 different ways. One is intracardiac echo and second is transesophageal echo. And so now we have in this particular patient an intracardiac echo, but just 2 or 3 slides from my colleague who has done a outpatient transesophageal echo for this patient. Show that.
We've lost sound for Shiva. Can you hear us?
Yeah, I am able to hear you. See, this is the
nobody was talking then.
Transesophageal echo.
I mean, we thought we lost you again. So you are showing here bicable view and short axis view, and now in the port chamber view, right?
No. Can you show Anand in the next picture? Yeah, keep running it live. So this is a bicaval view with the color flows. In the transesophageal echocardiogram, the ASD measured 16 millimeters. And show the next picture. And this is a 3D en-face view with what you are seeing on the, this is a right atrial en-face view. On the right side of the screen, right hand of the screen, you see the aortic root. Superiorly, you see the superior vena cava, and again, the hole was measuring around 16 to 16.5 millimeters. Now, can you come live on this? Srija has got some intracardiac echo pictures. Show the first echo, Srija. Go to the echo big. So this is.
What kind of echo are you using? Are you using Echocardiogram or are you using?
This is the ViewMate Z. This is the ViewMate Z from the St. Jude, mounted to a Philips CX50 machine. So Srija, can you go ahead?
Yeah, so these are some of the echocardiogram eyes images. We have measured the ASD, and the size is ranging, maximum size we got is around 15.6, millimeters is the maximum size.
Yeah, keep showing all whatever you have acquired. So now.
Yeah, bicaval.
This is the 64 element non-3D simple intracardiac echo catheter. So now we are trying to get into the upper pulmonary vein.
While you're doing that, if you were given a choice, would you actually ever use this in cardiac echo? Because if you get used to 3D COE, it looks rubbish.
What is that? I didn't get you. Is it Gareth?
So it's Iqbal. Hi there, Siva.
Hi,
I
Iqbal.
don't disturb you, but it's a great demonstration of the 2 different picture qualities. You're going to use just intracardiac echo. There's no COE here, is that right?
In this particular patient, we are doing it without transesophageal echocardiogram, and in the next lab, we are trying to get a patient with transesophageal echocardiogram. That patient is being intubated. Here, this patient is unconscious, conscious like she's awake now.
I'm going to take my comment back. You never heard it, okay?
This patient is not having a transesophageal. She is listening to me as I talk to you.
Sure, she must be absolutely fed up.
Yeah, actually, it is late evening, 8 o'clock. She should be hungry now. Are you hungry now? No? She says no. You are thirsty.
Well, she has to say no.
She says that she wants to drink some water. Sister, would you be happy to give her about some 50 ml of water?
That's very generous.
Hopefully, Shaq, in another few minutes, I'll be able to give her dinner as well.
drinking more than that weight.
Shiva, while you're doing this, how do you evaluate by intracardiac echo, short axis bicable, and let's say a 3 or 4 chamber view? You only measure the defect in one view, right?
Correct.
Defects are
Correct.
So how do you evaluate that?
Correct. Actually, what I do, in fact,
can you show us the short axis?
Actually, what is happening is the catheter flips a lot, and hence I have got it locked into a particular position where it is quite stable. When I tried to change over the axis repeatedly, the catheter was rotating too many times, and hence it was disturbing me. This is, I would say, is the best image. But the transesophageal, the largest dimension was 16 millimeter. So I was thinking about taking a 20 millimeter, but my colleague Srija says that 18 should be good enough. So I'm going to take an 18 millimeter cocoon device, show the device to the audience. The peculiarity of a cocoon.
Siva, just before you open the packet, so are you a balloon sizer or a non-balloon sizer?
I don't balloon size at all, except in cases of multiple ASDs where I interrogate the septum. I use a balloon to ensure that 2 wires don't cross the same defect. But when it comes to a standard ASD, I don't balloon size at all. There are.
I'm going to show of hands to the audience. Who balloon sizes here? Balloon sizing. And who doesn't balloon size? Come on, own up. Oh, it's pretty even. 50-50. Siva, you're all right.
Siva, this is Srinath. Before you get the device up there, can you tell the audience how are you going to choose whether it's going to be ICE versus EE? The other question I have is, this is a moderate sized ASD, and you've not clearly demonstrated all the rims.
Srija, live, you are live now?
Deficient SVC
You are not
rim.
live.
What about the posterior rim and the IVC rim, which can be crucial?
All the rims, we checked it on transesophageal, which are quite roomy. And
Shiva,
yep.
I mean, I think for the sake of audience, I would definitely show a short axis. I mean, you have to at least 2 orthogonal, right? You're showing bicable.
Can you show me the echo also parallel?
And then show us short axis.
Echo parallel. Can you hold it here, Alka? The same position. Okay.
So Shiva, I would move this catheter. You know how it's facing this way? Rotate the catheter completely and bring it under the device. You'll be able to show short axis.
Zahid, what is happening is the catheter makes a 180-degree turn suddenly. So what I will do is I will
keep holding it. I would hold it. It won't make a turn up around.
Is that with his foot? He's only got 2.
Yeah, so rotate the catheter for a second, seriously, after you deploy the device, regardless of, I agree with you, it's a simple defect, no need to, but if you're showing it by eyes, I would at least go 2 orthogonal so we can evaluate 4 rims.
He's completely ignoring.
No, Shaq, I tried Shaq in this, see this is the superior vena cava, that is the superior vena caval rim.
We saw that for a long time. We need to see the short axis.
I think he was after the aortic rim and.
Yeah, rotate it in your medial.
There you go.
I'm doing.
There you go. It's getting warmer now. See that? I would rotate even more. It's getting warmer, but not hot.
Very good. There's the AV rim.
We have I'm not able to torque it very well. The reason being, this has been reused, and we have an ethylene oxide sterilized catheter.
Well, at least you have a reason.
Yeah. Okay. So now show us the 2 discs and bicable view.
Again.
I'm going back. So this is superior vena cava. 1 second. Make the image darker, Srija. It's too bright. Yeah, color now. Move the color towards the right side of the screen. That is the superior vena cava. Fine. So pretty happy about the images. Srijay, just one check on thoracic echocardiogram and then we are going to release it now. So it's an 18 millimeter device on a maybe 16 defect with good margins. Ready there? Ready? Punctures?
Can I ask the panel, so if you're not going to balloon size, then is that enough of an upsizing, an 18 into a 16? What does the panel think about that?
So I don't use intracardiac, I use DOE, and depends on the floppiness. So if it's floppy but similar sort of location, I add 4 millimeters, and if it's rigid rim, then 2 millimeters above.
Sure. Your floppiness is just your feeling. So floppiness is just your feeling. So that's the reason why it depends the patient. But in case with some floppiness, I would balloon size to assess the compliance of the septum.
Yeah. Okay.
So-
No, that's fair enough.
So we did a wiggling Minnesota wiggle now, and you can see the picture. It's quite looking satisfactory. The thoracic echo also is looking good. Srija, your hands are coming in between.
So as far as balloon sizing is concerned, I abandoned in 2001. So I balloon size PFOs, but I don't balloon size things.
I'm just stuck in 2001.
Fluorostore.
Space Odyssey.
Yeah.
And so, if you stop balloon sizing in 2001, how do you select, which is the original question, floppy rim versus non-floppy rim, and how do you select the device?
Exactly what you said. I mean, I will look at the floppy.
TE probe inside.
The thick septum, secundum, and then you can add that floppy. You know, when you balloon size is going to do two things. It's going to get whole defect round, so you get an average diameter, and second, all the thin serum will curve, and you get the side diameter.
Hi, Shaq, can I?
However, in this size live case, many years ago, they
Show the
was
release
average,
sequence.
which was the defect size was about 10 millimeter or 12 millimeter.
Keep running.
So after Penas, the size was something like between 12 to 14, but the actual size on the balloon it was 22. It happens, especially when the aortic in the bold aortic valve is protruding, or some similar situations. So that's the reason why I balloon size in some patients.
Srija, just show apical fourth chamber.
Can I make a comment on balloon sizing? The thing is that especially when you're dealing with ASD after pulmonary stenosis,
Make it larger.
dilatation, or pulmonary atresia perforation, I think the septum primum is so patulous in these patients that what you see as 9 or 10 when you balloon size will turn out to be 18, 19. So this is one subset where I will 100% balloon size. I do most of the patients with balloon sizing, but this is one subset, sure shot, and of course multiple ASDs as somebody said.
There are places that you can, and you should. We are talking about simple secundum atrial septal
Echo big?
defect.
Yeah, I mean, but
Echo big.
following pulmonary stenosis,
Echo big?
they look very simple. Very simple. But size will fool you in these patients and you will end up with embolization, most often on the left side.
You're okay?
Okay, Shiva, what's going on?
So basically we have released the device, and the device is in stable position. This is thoracic echocardiogram. And we just want to show you one transesophageal echo guided ASD on the other lab. So I'll just move to the other lab and show you a TE picture there and the device. Srija, can you do the TE picture there?
Okay, big hand for Shiva and his team here.